tool to depict many conditions in the body, starting from the superficial organs like the skin and the subcutaneous tissue, going to deeper structures like the abdomen, and where you can see the liver, you can see the spleen, you can see the kidneys. And of course, as we have all known in the previous presentation by Professor Fahal yesterday, no part of the body is protected from mycetoma infection, unfortunately. As we have seen, it can involve many parts of the body. The infection usually starts at the subcutaneous area, but unfortunately there are many methods of spread, among them the hematogenous one. And we have seen yesterday a case of hematogenous spread where there was involvement of a deeper structure without cutaneous lesion. And that's why other imaging modalities are also recruited and get involved in the process of imaging. These mainly include the CT and the MRI, and of course our very lovely plain radiography. Plain radiography remains the gold standard imaging tool for many conditions, despite the involvement of CT and MRI and other imaging modalities. As the professor said, during the coming 2 hours, we will cover most of the ultrasound technique. We will see patients. Then after that, Dr. Raif will continue and will present short presentations about plain radiography and the others. And of course, as you all know, ultrasound has many advantages. The most important advantage, I think, is that it's radiation-free. Secondly, it's cost-effective. That means it's very cheap, it's not expensive. It's a portable tool. You can carry this machine with you, and even there are laptop-based machines, and now we have mobile-based machines, of course. Concerning mycetoma imaging, as you know, most of the cases are involving the feet, involving the hands. More than 70% of the cases are at the feet. So here we use a linear probe, which is this one. This kind of probe, this is a linear one. As you all see, there is written here clearly 5 to 12, and this is the frequency of the probe. This linear probe, which has a high frequency, 5 to 12, these are megahairs, billions of hairs. It penetrates superficially, so it can depict the grains, it can depict the foreign bodies, it can depict other conditions, because not every lump or not each lump is a mycetoma lump. In our center and the field, we have picked up many cases which came to be at the end of the day other pathologies. The other probe that we use is this one. This is a convex probe. The frequency of the convex probe is ranging from 2 to 5, and this is again, these are megahairs. This is a low frequency probe. It penetrates deeper. Through this probe we can image the kidneys, the liver, the pelvic structures, the spleen and the rest. So as you can all see, this is a machine. See? You can put it on a tabletop. It has a trolley which is located there at the center. You can take it in a bag. It's very compact, it's very smart, and fortunately enough, most of the ultrasound machines are very durable. It's very rare for ultrasound machine to get ruined or to be destroyed or to be malfunctioned. Now I will start examining the patients. I will start with my first patient, is a patient of foot lesion. I will do the scan in front of our eyes and you will see what I'm doing, and I hope that this session will be an interactive one so that during my scan, if any of you currently has some comment or question, we can answer that. Okay, let's start. This is our first patient. He has a lesion at the foot, as I said. First of all, I have started the scanner, as you all see, and on the screen we can see a rectangular field. This rectangular field has, okay. This is the site that I'm going to examine. Okay. The patient has a foot, left foot long. By inspection, it's not that visible for you, but when you palpate deeply, you feel a lump here. Okay. This is what has been done by our colleagues in the clinic. Now, I will put the probe just on the lesion, and I will show you what we see. Okay, this is available anatomy that we can see here. Of course, this is the skin, this very hypochoric layer, which is a black one. This is the subcutaneous area and the fascia of the foot. And here we have the tendons, and here we have, of course, this is a tendon, this black structure. And here we have a bone. The ultrasound can tell us whether this lesion is located superficially, whether it's a multiple, whether it's a single or multiple cavities. These cavities, are they aggregated together or are they separated? Is there any involvement of the deeper structures? Is there involvement of the bone? Is there any bone destruction? And of course, I can put the Doppler to show you the hyperemia. Is the lesion hyperemic or not? Okay, now this is the normal anatomy. Now, concerning the lesion, as you can see here, at this side of the cursor, this lesion is a small subcentimetric oval-shaped hypochoric lesion containing scanty amount of fluid and containing this echogenic grain. So, by analyzing the contents of the lesion, I can tell whether this lesion is a mycetoma or not, and even I can tell whether it's of an eomycetoma or of an actinomycetoma. As you can see, this lesion has a wall, this is a wall, and the white structures which are located here, these are the grains. They have sharp echogenicity. We can see them very sharply in comparison to the case which of an actinomycetoma, which you will all see with me. This sharp echogenicity and the size of grains, which is around 2 to 5 millimeters, this is in keeping with, or it directs to the line of eomycetoma. As you can all see, this lesion is confined to the subcutaneous area. it hasn't any deeper extension to the tendon, and it hasn't deeper extension to the bone. So this is a very early disease. We cannot see any foreign body at the site of the lesion because sometimes we take up foreign bodies. So this is the first case. It's a straightforward case of mycetoma, an early disease, a single cavity, which is located superficially. And when I put the color, this is a color box which can be modified. You can make it small and you can enlarge it. Here I'm making it small. The smaller the box, the better is the color that's obtained. So there is no hyperemia. This means that this lesion isn't hyperemic. It isn't a vascular lesion. And this is a very early disease confined to the subcutaneous area. I would be glad to hear from you if anyone has any comment or any question before proceeding to the second case.
Yes, Dr. Mustafa, we have questions here.
Okay.
Hi, this is Wendy van der Zande, and I had a question. You said you could differentiate between mycetoma and actinomycetoma. Is that because of the melanin? So would mycetoma caused by a white grain also be different from an actinomycetoma grain?
Okay, thank you for the last question. Yeah. By ultrasound, it's easy to differentiate between the two types. Concerning the grain size and concerning but thank you for the question. As I said, by ultrasound you can differentiate between these two types. First of all, the echogenicity tell us whether this is EO or actino, because a grain of an mycetoma, as we have seen here in this case, is sharply echogenic. It's sharply echogenic. You can see it. You can pick it up very easily. Whereas a grain or grains of actinomycetoma, they show fine echogenicity. You might see just a haze of echogenicity. Sometimes we see an echogenic lesion without definable grains. Still, it goes with an actinomycetoma. And of course, some point that I would like to emphasize. At the end of the day, we have to take a biopsy, and it will tell us the final diagnosis. But what I mean from ultrasound, you can say this is EO or actino.
As Dr. Mustafa said, it's difficult to have a very clear conclusion that this is an actinomycetoma from ultrasound.
But you can
We will tell you this is a mycetoma, not mycetoma lesion. This is an important issue. The other thing that is the size of the grains and where is the grains at the bottom of the cavity or floating in the fluid. So this is important differentiation between the two. But I don't think the melanin has a lot to play in differentiation between the two. So it will be the size and the way is the grains within the cavity itself. So melanin, because she's thinking about the melanin as an important cause of this, but it's very difficult to say the melanin is differentiating between this and that.
Yes.
Yeah. Usually, as Mustafa will tell you in the next case, usually we find the actinomycetoma, the actinomycetoma is floating in the fluid. And sometimes you find them sticking down at the bottom of the cavity in this. And this is the way to differentiate between the two. It needs a lot of experience, and at the end of the day, you have to do some sort of histological diagnosis for this patient. Yeah. But the important thing, it can tell you this is mycetoma, not mycetoma. This is the important issue.
Yes.
Well, in the field, you want to know is this is a sol granuloma, or it is a lipoma, or it is a mycetoma. And after that, you go for further investigation. And that's why I said yesterday, we need to have a very point of care test for the mycetoma patient like this. Please, Professor. Yes.
Do you get mixed infections, or is it always a single organism?
Very quaint, very important question. It's always the single infection. One hit, but sometimes within the grains, it may be more than one organism. This is something new. But I know one of them will be more prominent, and this is a paper coming. And hopefully in the conference, somebody from Italy is going to talk about this. Okay? It is commonly it is one organism within the grains of the site. But some of them may have some other organisms. But one of them will be the major, the prominent, and the dominant one of these. But yeah, you mean actinomycetoma or emystoma project? You mean combination of actino or emystoma, or yeah. Yeah, it's commonly either EU or actine separately. Yeah. Absolutely. Yeah. This is why one of them will be the major organism there. Why one of them will be the dominant organism there. Yep. Yeah. Good suggestion. Yes. Absolutely. All right. Yes. Thank you. Can you see? Yeah. Yeah. Very few cases have combination of actinomycetoma and emystoma in the same patient. I came across one or two cases maximum. Yes, please. Yeah, actually, the accuracy of the ultrasound, can somebody tell us about that? Okay. Yes, Mustafa, can I see the second question?
So now